So like in most situations where the tumor is either advanced and unresectable or metastatic, like in this case being discussed, the standard of care would clearly be systemic therapy. As much as we are all wanting the field to move into targeted therapies directed at specific subsets of patients, for the time being, conventional chemotherapy remains the standard of care. So as this patient received gemcitabine and docetaxel, that's a very reasonable regimen and approach for patients with leiomyosarcomas. There is evidence to suggest that it is just as active as other competitive regimens may be in patients with gynecologic origin leiomyosarcomas. For the other sites, I think again there is evidence of activity and therefore it would be a reasonable choice. Whether one starts with one regimen or another, in this instance a gemcitabine docetaxel regimen or an anthracycline-based regimen, depends on several factors. Some of them are related to the origin of the tumor. Ifosfamide as a drug is not very active for the non-uterine leiomyosarcomas. So therefore, as you see in this particular patient, after gemcitabine docetaxel, patient got doxorubicin and dacarbazine or DTIC, which does have some selective activity in patients with leiomyosarcomas. Whether one uses regimen A first and B later or B first and A later is sort of becoming a blend, if you will, over a period of time. I think there are several other factors that go into the decision making. Patient's performance status, patient's lifestyle, their own wishes in terms of how they want to carry on with their day-to-day routine, because the side effect profiles are clearly different. But in general terms, I think systemic therapy would be the standard of care. Chemotherapy is the mainstay of systemic therapy as we speak today. And the top two regimens that are used would be a gemcitabine docetaxel or an anthracycline-based regimen.